on to talk about drug distribution. Once the drug gets absorbed into systemic circulation, and that's not true for every drug, of course, but for many it is, we're going to look then to get the drug to be into the site of action. And where the drugs go from bloodstream and moving on beyond the bloodstream into tissues or into other areas depends on the lipid solubility of the drug. Some drugs are distributed to tissues pretty slowly, meaning over a couple of hours, but many drugs are rapidly distributed. And probably the fastest of drug distributions are general anesthetics that are very fat soluble that are distributed into the central nervous system within just a few seconds. So as we think about distribution, we think about the drug going from the plasma in the blood to extracellular fluids and then being maybe deposited in fat if it's particularly related to adipose tissue, or intracellular fluids, or to other fluids, maybe the central spinal fluid, the peritoneal cavity, the synovial membrane, or synovial fluid. Even in pregnant women, we're concerned or think about drugs actually penetrating across the placenta and exposing the fetus to that drug. So are all factors that need to be thought about when we think about drug distribution. The more quickly a drug reaches its target organ, the more quickly it has an effect. So drug distribution is a rate-limiting step once the drug enters circulation before we begin to see the physiologic properties. Generally, though, the fat-soluble drugs cross membranes easily and are well distributed, whereas the water-soluble drugs are not, where the fat-soluble drugs are distributed readily to a lot of various tissues. So let's look at first a water-soluble drug and consider water solubility as a factor related to how drugs are distributed. Let's first imagine that we give the dose of a drug intravenously, and if we look at this box where these stars are located, consider that the 6 liters or so of the bloodstream, the circulatory system in an adult. And right after we give the IV push administration of the drug, virtually all of the drug ends up within the bloodstream. Because it's water soluble, over a period of the next few minutes, the drug will begin to distribute throughout where it wants to end up in the body. So some of it will remain in the plasma, and other molecules will find its way out of the body and distributed through the body. Ultimately, where the drug gets distributed depends on whether or not the area has some water solubility associated with it. And you'll notice that in this case, because it's a water-soluble drug, a fair amount of the drug actually remains in the plasma. After complete distribution, only some of the drug gets around the body. For a fat-soluble drug, let's imagine what happens in the same scenario. We give the fat-soluble drug, and first, right after we complete that fat-soluble drug administration, what you end up with is all of it in the bloodstream. But what ends up being quite different is that you'll see more drug distributed when it's a fat-soluble drug, because by its very nature, the body has more adipose tissue and has more fat solubility locations to go to than just the plasma, as we saw with the water-soluble drugs. Ultimately, we see that drugs distributing, and a lot of the drug distribution happens throughout the body with very little left in the bloodstream for a very fat-soluble drug. Fat-soluble drugs, by their very nature, cross membranes well, and that includes the blood-brain barrier. And so what you'll find is that drugs that are fat-soluble generally penetrate the central nervous system quite well. And so that's going to be a consideration whenever we use a neuro or psych drug, drugs in neurology and psychiatry. Every single one of them, save one drug, is associated with very high fat solubility so that it can cross the blood-brain barrier. And water-soluble drugs just don't get into the brain. The only exception to that is the very small molecular weight lithium. Lithium is used in psychiatry for treating bipolar conditions, and mania. And what you'll see lithium is that it's very tiny. In fact, if you remember in chemistry, lithium itself is an element. It is so small that lithium can actually get through membrane pores and be distributed in the central nervous system relatively easily. But most other drugs we use, particularly those used with neurologic or psychiatric implications, are all, by their very nature, fat-soluble drugs. Important to consider that over time, when we look at distribution, we can look at the slope of or the decay of a drug on a concentration time graphic, and you'll notice that in the first couple of minutes, the big drop in the concentration of unit per unit time isn't that the drug's leaving the body, it's the drug is leaving the bloodstream and going and just being distributed throughout the body. So that first initial drop in blood levels are associated with drug distribution. There are reservoirs where drugs can hang out. One of the places that we see drugs hanging out or accumulating are on sites where they have some affinity or binding. The two classic places where drugs will bind to temporarily, not exerting a physiologic or pharmacologic response, but they just kind of hang there because of their construction, their three-dimensional, maybe electrical charge configuration, is to proteins in particular. The two protein areas where you'll see drugs bind is one is proteins in the plasma, particularly albumin in the plasma, and second is tissue binding sites, particularly protein binding sites in the rest of the body. Sometimes that's muscle, sometimes that's some other area of the body where the drugs bind to and sort of hang out as a reservoir. Let's look at how this reservoir as it relates to serum albumin relates to highly albumin-bound drugs, protein-bound drugs. An example here is dilantin or phenytoin. Phenytoin is an anti-epileptic drug or a seizure-controlling drug. And phenytoin is associated with a high degree or high percentage of the drug that's in the bloodstream at any point in time is electrically bound to albumin. Really only about 1% of phenytoin is not bound to albumin. The other 90% or so typically is. That's true when there's a lot of albumin around. So in this graphic here, you'll see that while the total amount of phenytoin molecules or the phenytoin level in this blood sample might be considered 10, maybe 10 milligrams per liter, the only amount of drug that is not bound to albumin is one of those 10 or 1 milligram per liter. And it's really only that free phenytoin, that unbound phenytoin, that is able to cross membranes. When the drug is electrically bound to albumin, that renders the drug like a very large molecular weight drug, and as such, you'll see that it really won't cross membranes very well. If I had a similar patient, but with a very low albumin level, you would actually expect to see in this case that the percentage of drug that is not bound or free to cross membranes is higher. In this case, on the right, 3%, 30%, for example, of the drug would cross membranes because it's not bound to albumin. And so this is important for highly protein-bound drugs, albumin-bound drugs, where patients have low albumin levels because of malnutrition or some other reason. In those circumstances, we actually would be concerned about, even though their total level that the lab would measure is the same in both patients, the patient on the right who has less albumin has 3 times as much drug that can cross membranes. And so that patient on the right may actually exhibit what looks like dilantin toxicity because their free levels are higher. Dilantin or phenytoin in this case is a drug where you will have the tools available to you to estimate what their level would be corrected for, or corrected phenytoin level based on their albumin and other things that bind to albumin. So you'd be able to estimate how to interpret that level of 10 in this patient. More on that when we get later in the year. But recognize that for about 5 or 10% of drugs we use in practice that are highly bound to serum albumin, this concept of what's bound and what's free become important about how the drugs get distributed ultimately to the receptor sites and work, and ultimately to their sites of action. So plasma protein binding happens when the drug actually complexes with the albumin or the other molecule. It's usually an on-off phenomenon like in receptors. It's usually an electrical charge attraction that becomes a reservoir for effect. When we measure a drug, typically if the lab does a measuring of drug, they typically measure the drug protein and the protein complex together. They typically will not measure the free level of the drug. The free level of the drug, though, could be measured. Usually, though, most labs, if they do it, it's a send out. It's a 3 or 4 day delay to get the results. And in clinical practice, that 3-day delay is just too much time to wait to make a clinical decision on the patient who's in front of you. So this concept, it's also true that in addition to a drug binding to protein, you can have multiple drugs trying to compete for the same protein sites, and one drug could actually bump the other drug off of protein and increase the free level of that second drug. Other factors that affect the ability of a drug to bind to it is the concentration of the albumin or the other plasma proteins, the binding sites, the number of binding sites that are available on the protein, what the drug's affinity is for that protein, and the acid-base balance of the patient, which affects ionization properties. Factors that can affect highly protein-bound drugs. Well, a lot of disease states, particularly liver disease and malnutrition, are associated with reduced albumin levels. And so you have to kind of keep that in mind when you have someone, for example, with liver failure or someone who has a low albumin level because of other health conditions, for example, nephrotic syndrome, a type of renal condition, a renal disease, or folks who are malnourished and don't have much albumin either. The tissue binding outside of the bloodstream can happen too. It can be in adipose tissue, it can be in bone, it can be in muscle. And particularly in adipose tissue, some fat-soluble drugs can hang around a long time in the body because they have affinity for this fat tissue. There can also be barriers to get the drug to distribute. One of the barriers we think of is the blood-brain barrier, where you are, to get the drug across the blood-brain barrier to have it work in the central nervous system. That's a consideration. Does it cross the blood-brain barrier or not? Other barriers include the placenta or areas where there's poor perfusion, or if there's an abscess. We'll talk about each of these. The blood-brain barrier specifically is a layer of capillary endothelial cells that line the blood vessels entering the central nervous system, and only fat-soluble drugs get across the blood-brain barrier. So that's going to be important not only in neuropsych drugs, but if you're treating meningitis, you have to consider, does the antibiotic that you're going to use actually penetrate across the blood-brain barrier? Is it going to get to where you need it? So you might have a perfect antibiotic to consider using for the pathogen you suspect is there in the brain or in the cerebrospinal fluid, but you can't get the drug to that site, then that's not a practical drug to use. So think about the drugs that aren't going to cross the blood-brain barrier, particularly those that are highly electrically charged or very large, not lipid-soluble. Those drugs actually don't cross the blood-brain barrier. There's also the placental circulation is affected, affects actually drug distribution across the placenta. And so many drugs, particularly large molecular weight drugs, don't cross the placenta very well. So let's use a classic example in clinical practice. Women who are pregnant can have a higher risk for a clot forming in their legs, a deep vein thrombosis. And the concern is we have to treat that deep vein thrombosis. There are two basic types of therapies you can use. You can use oral drugs like Coumadin or warfarin, which are small molecular weight, or you can use some of the heparin-related derivatives, which are much larger comparative to warfarin in their molecular weight. And typically in clinical practice for treating a deep vein thrombosis in a woman who's pregnant, we would not want to use a drug like warfarin or Coumadin because it will cross the blood-brain barrier and cause harm to the fetus. Instead, the anticoagulant we're going to likely use is one of the heparin derivatives, usually enoxaparin, which is compared to warfarin a very large molecular weight substance that won't cross membranes very well and is safe to use in pregnancy. Other things that are problematic and barriers to getting drugs distributed are where there's poor perfusion, if a patient is in shock, or have had ischemia or infarction, or peripheral vascular disease. And peripheral vascular disease is a real issue for when we are deciding to treat a diabetic foot ulcer, for example, in a diabetic with poor circulation to the lower extremities. Then we kind of know that, hey, already I'm going to have difficulty in getting good blood perfusion to that site. And so the antibiotic I'm going to pick and the dose I'm going to pick is going to be really account for getting enough drug to that site of infection. And so for diabetic foot ulcers, for example, we want to make sure we give enough drug that compensate for the difficulty in the poor perfusion to that area. And the other issue is our abscesses. Abscesses really are walled off, poorly vascularized areas of infection. And typically with an abscess, antibiotics are helpful, but the real treatment modality is surgically draining the abscess. Whether that's someone who has an abscess in a tooth, they need a root canal, for example, to drain that abscess, or whether or not they have a surgical site with an abscess where a surgical drainage is going to be important for improving response to that, because abscesses notoriously are poorly set up or are able to be perfused. Okay, let's talk about a concept that is a relatively complicated concept, and maybe in all of pharmacology is the single most difficult concept that patients, not patients, but students may have an understanding of. So please try to be patient with yourself as we explain this concept of volume of distribution, and try to consider going over it a couple of times. First of all, the concept of volume of distribution is a theoretical concept. It's not an actual thing, it's a theoretical way of thinking. It's a calculated value that represents the volume that would be required to contain the dose you gave if the dose were evenly distributed at the concentration that we measure in the blood. So keep in mind that when we go to measure drug levels, we typically do it by convenience in the blood, because that's a relatively non-invasive way to sample the quantity of a drug in the body. But we already know, based on whether the drug is fat or water soluble, if the amount in the drug is going, the amount of drug in the bloodstream or in the plasma is going to equal the amount of drug anywhere else in the body, and most often that is not true. Based on why drugs want to stay in the bloodstream, either they're protein bound to albumin, or they're more water soluble, or whether the drug wants to hang out outside of the bloodstream. For example, the drug is fairly fat soluble, or the drug binds to other tissue sites, then those are factors that are going to affect whether or not the concentration we see in the blood is representative or not representative of the whole amount of drug in the body. So typically we are going to know two things about the patient, or maybe three things about the patient, but if we know two of them, we can calculate or estimate the third one. We will know, for example, the amount of drug we gave. We will also know the amount of drug in the plasma after the drug has distributed. So we give, let's say, 100 milligrams of the drug. Doesn't matter what the drug is. We give 100 milligrams of the drug. If we know that most of the drug distributes in 30 minutes, which is true for most drugs, then we give the drug by IV push, for example, 100 milligrams of the drug. And we then measure the blood level 30 minutes later, after the drug is distributed to where it's going to go, and it begins to be in equilibrium coming back into the bloodstream as well, then those two factors will tell us a lot about where the drug goes. If we give 100 milligrams of drug and very little of that drug remains in the bloodstream, by default, that drug is mostly outside of the bloodstream. and therefore we consider that drug having a large volume of distribution. If, however, the amount remaining in the blood is quite high, we know that very little of it went outside of the blood. So the volume of distribution is a way to think about how big would the rest of the body have to be to explain the concentration we observe in the blood right after the drug has completed its distribution. And that can be calculated with this formula. The volume of distribution, which is the units are in liters, is equal to the dose we give, usually in milligrams, divided by the concentration, which is milligrams per liter. If you remember algebra and what you do with your units, the milligrams above and below are sort of cancel each other out. What you end up with is the unit for the volume of distribution is in liters. So let's think about a couple other ways to approach or think about this. One is the apparent volume of distribution. What it is, it's based on the sampled volume we've got. How do we account for the total amount of drug that's distributed in the body? So this one graphic is an example of that. Here is a second graphic that sometimes helps people think about the volume of distribution. The drug at the top, where we gave, let's say, 12 milligrams of the drug, 2 milligrams ended up in the plasma and 10 milligrams in the rest of the body. How big would the rest of the body have to be to explain the concentration we observe in the plasma? It would have to be 6. The second one in green is this is a drug that has a large volume of distribution because not much left in the plasma. Most of it ends up in the rest of the body. And so here, to explain the concentration we see in the plasma, would have to have a volume of distribution that's large. That, by its very nature, that middle one, is most likely a fat-soluble drug, a drug that likes to hang outside of the plasma. The third or bottom one in red represents a drug that's most likely either highly bound to albumin or very water-soluble. That's a drug that has a relatively small volume of distribution in that the concentration in the plasma is higher, and therefore would explain the rest of the body's concentration. It would have to be, compared to other drugs, smaller volume of distribution. In general, based on the weight of a patient, a drug that has a volume of distribution about 1 liter per kilogram is a drug that is pretty much evenly distributed both in the blood and in the body. And that would be a drug that is both fairly water and fairly fat soluble. It's not too much of either. And if you think about this, a liter of water weighs a kilogram. So in a sense, the volume of distribution per kilogram of patient weight of 1 means that it's pretty much what you see in the plasma is on average what you'd see if you've got a tissue sample of anywhere else in the body. A volume of distribution that's less than 1 liter per kilogram, particularly drug that is a lot less than 1 liter per kilogram, by its very nature has more drug in the blood than the rest of the body, and these are generally very water-soluble or very highly protein-bound, plasma protein-bound drugs. These drugs generally have much higher levels in the blood than they have elsewhere in the body. And a drug that is a fat-soluble drug generally has a very large volume of distribution, and what you end up with is a very small amount of drug in the blood after distribution. Most of it ends up in the rest of the body, maybe in adipose tissue or somewhere else. And many of the drugs we use in psychiatry, particularly the benzodiazepines like Ativan or Valium, are associated with very large volumes of distribution, and the amount measured in the blood is actually quite low. There are things then that obviously affect the volume of distribution that we've alluded to. Protein binding does, and fat solubility does. Now, how would we figure out what our first initial dose of a drug is? Well, knowing the volume of distribution and what we want for a blood level, we could estimate what dose we give. And here's a formula that does that. Now, in practice, you will never have to do this. You basically open up a reference, and it's going to tell you a milligram per kilogram or a standing first dose you would give a patient. And so you don't really have to do this. But in practice, clinical pharmacists may actually use this formula to estimate the first dose we're going to give, for example, for a patient on vancomycin, for example, an antibiotic we use in the hospital a lot. So basically, the volume of distribution we're going to use is we don't know that patient's volume of distribution. What we instead know is, on average, the average patient who looks like this patient, I'd expect the volume of distribution to be X number of liters based on the thousands of patients who have gotten this drug in the past. So we take the volume of distribution in, maybe it's 1 liter per kilogram of weight times 100 kilograms means 100 liters. 100 liters times, we want a level of 10 milligrams per liter. So if it's 100 liter volume of distribution and we want a blood level post-distribution of 10 milligrams per liter, we're going to give 1,000 milligrams of the drug. Now that assumes that the salt factor, meaning the percentage weight of the drug we're giving, like remember we talked about aminophylline a bit ago, is 1, and that's almost always 1, and that the bioavailability is 100%. And if we're giving vancomycin, for example, intravenously, then it's going to be 100%. So in this case, let's say whatever the drug was, we're going to give 1,000 milligrams based on what we know for the population average for volumes of distribution in this 100 kilogram patient. I'm going to expect that 1,000 milligrams is going to get me a blood level of about 10. If I want to give a second dose, so I know that the level is already at 5, and I want the level to get to 15, then I can just look at the difference in the levels. I use the same formula, but I look at the volume of distribution, let's say for this patient it's 100 liters, times the difference between 15 and 5, that's up another 10 milligrams per liter. And let's say the salt and the bioavailability factors are both 1, doesn't really matter. Then what we end up with is I have to give a gram to this patient to get the level from 5, which it is now, up to 15. So basically I want to just get it up 10 more. So in practice, you will probably never have to calculate a volume of distribution. But let's talk a little bit about why understanding a volume of distribution is important. Let's say JM, patient weighs 70 kilograms, receives his first dose of gentamicin 160 at 8 in the morning. Half an hour later, his gentamicin level is 7.2. So what's his volume of distribution? And you can follow the calculations here. The volume of distribution is about 22 liters or 0.31 liters per kilogram. Was that what we expected? Well, actually, based on population norms, we expect it to be lower. But in this patient, he actually may be a bit fluid overloaded, and so he has a larger volume of distribution, probably meaning than we'd expect by the population. So it probably means that he has more fluid on board because gentamicin is the type of drug that likes to hang out in water or in fluid. Now, in practice, you don't really probably need to get to this level of detail, but it's important to recognize that not every patient is going to respond identically to the same dose we give, because a patient may have more or less fluid on board, they may have more or less tissue binding, they may have more or less albumin for binding drugs. And so the population average for a volume of distribution isn't the same as the individual patient's volume of distribution. And so recognize there's a lot of variation in drug dosing from patients, but when you open up your drug reference and they tell you to give X milligram per kilogram of this drug to achieve this level, recognize that there's going to be some variation from one patient to another based on their fluid status, their albumin store sites, other factors that relate to where the drug gets distributed to.